Welcome back. Today we are going to talk about first aid in the adult care home. So, when we talk about first aid in the adult care home, first thing we need to think about is to be aware of the advanced directives that the resident has. You may not necessarily need to know if they have a living will or if they have a durable power of attorney. That's not really something necessary for a CNA to know with their daily job. However, you need to know, do they want to be resuscitated? Now, we already kind of talked about the do not resuscitate back in Unit 18, but I'll kind of refresh you. That do not resuscitate means that when the heartbeat and or the respiration stop, no CPR will be done. That person is deceased, they have expired, they are no longer living, and we are going to let them go. So, know which residents of yours have a DNR and which ones don't. If you don't know, find your charge nurse immediately. If you've got something going on and you think that the person might be dying and or already deceased, then you need to get that charge nurse right away anyway, even if you do know their code status, if they are a full code where you do everything or if they're a do not resuscitate. So you want to call for help, if possible, without leaving the resident. This is the time where you can put that call light on, start yelling for help. I know we always tell people, well, you need to be quiet, you need to be respectful. Know that this is these people's home, that you don't, go down yelling all up and down the halls. This is the time that that goes out the window. You need to get help, and you need to get help now. So start making as much noise as you can. Get somebody in there. Try not to leave that resident. So you want to absolutely call for the nurse. Now, if you're working someplace like an assisted living or a home plus where you don't have a nurse there, then your CMA is going to be the one that's in charge, your med aid. And they're going to be the one coming to check out the situation and maybe calling the nurse and having you do some other things while they're staying with the resident. So just whoever is in charge, call them, get help. Use only the first aid procedures that you are trained for. If you have a nurse that's on duty all the time, chances are you may never use first aid, and that's okay. But just in case they want you to do stuff, we want to make sure that you are prepared. So, only use those things for which you are trained and that are necessary while waiting for the nurse to enter. So, if you walk in the room and you see your resident on the floor, and they've got a big old gash on their head and they're pumping blood out all over the floor. Are you going to want to stand there and wait for the nurse or stick your head out in the hall and yell for somebody and then just stand there and wait for the nurse? No, you want to stop the bleeding. So that's what we're going to try to help you figure out. So I know our answer a lot of times is going to be for calling the nurse. However, we need to teach you what to do in the meantime while you're waiting. That's what this whole chapter is about. So you always want to follow standard precautions. If you've got that person that's on the floor, they've got a big old gash on their head, they're bleeding, they're pumping out blood everywhere, stop and put your gloves on. It'll take you 2 seconds, but you really need to do that to protect yourself, to protect your resident, because you never know, chances are maybe you know that there was something going on, you hightailed it in there, you didn't think to stop and wash your hands on the way in the room or use your hand sanitizer because there's a crisis situation going on. It happens. Well, your hands may be contaminated from whatever you were doing last, or if you touched the door on the way in and it hasn't been cleaned recently, or whatever. So you may get some kind of bloodborne infection from the resident, and you may give something to them if you're sticking your bare hands on their body when they've got all their blood exposed. So always stop and grab a pair of gloves. This is another reason why it's very, very important to make sure all of your rooms are stocked. Keep all your rooms stocked as much as you can. Keep all the gloves in those rooms. Make sure that the paper towels are filled. Make sure that you have all the supplies that you need. That way, in addition to maybe being knee deep in poop if somebody's been incontinent and you can't really stop what you're doing to go get more gloves or go get more wipes or whatever it is, this is an even more urgent situation where you cannot stop and go get something else if you don't have it. So stop, grab your gloves, then help the person, and don't leave them after that. So if you have somebody that maybe the nurse performs first aid and the person doesn't leave, then you know, you might have to continue some follow up care on them. The nurse may ask you to do vitals pretty often and just go check on them. That's pretty standard. Usually, you'll do vitals every 15 minutes times four, every 30 minutes times two, every hour times four, and then once a shift after that for 72 hours, especially if you've had somebody fall and hit their head. If they didn't hit their head, usually it's for 24 hours. But after that, if they do hit their head, it's for 72 hours. Just kind of keep that in mind. And that's something that you'll be trained to do whenever you start working at a facility, but it's good to know anyway. So, whether that person goes to the hospital or whether they stay there, you have to complete an incident or occurrence report. Now, this is a lot of times going to be different than your regular documentation that you fill out throughout your shift. This is going to be a special report that will help the facility decide, was the facility at fault? Was there anything that we could have done to prevent this? Was the staff doing everything that they could? Did we have the correct care plan in place? What can we do, to help this person from now on, and what can we do to prevent this in the future? That's the whole point of the occurrence report, not to try to find fault on anybody, not to try to find blame. Unfortunately, sometimes they do find that, but that's not the purpose. They're just trying to find out, did any of the systems fail? Did our training fail? Did we fail to notice that somebody needed more, additional education for that situation? So you always complete that incident report or occurrence immediately following the emergency as quick as you can. Because again, just like when we were talking about charting, think about your adrenaline's flowing, you're going, because this is not, it's not a good kind of excited, but you do get kind of excited in emergency. A lot of people do. If you don't panic, which please don't panic as much as you can help it, but a lot of people get kind of excited. It's kind of a rush. You get the adrenaline flowing. You're really, you're in the zone. You're helping somebody. You're saving that person's life if they're pumping blood out all over the carpet and you put pressure on their head to help stop bleeding. So, in the heat of the moment and right afterwards, you're going to start forgetting stuff. Right after that incident happens, it's all very fresh in your mind. You know exactly what that person looked like laying on the floor when you walked in the room and noticed them gushing blood all over the floor. You know exactly what they said or what they didn't say. A couple hours later, you may not remember. So it really is important to try to get all of that stuff written down as soon as possible so that you don't forget. So you always want to report any kind of change in condition. Now, this may help prevent our emergencies, and it's very, very important. You need to know your resident's baseline, so you need to know how they normally act. Is your resident normally confused? Are they normally alert and oriented? What are they acting like today? Is it different? Even if something just doesn't seem quite right, you've got that gut feeling something's going on, but you can't put your finger on it. You're just not sure what it is, but you really think that something's different about that person. Trust your gut instinct. Go tell your nurse. Tell your nurse what it is about that resident that makes you feel like something's not really going on, or something's not right. Something is going on. Then your nurse should follow up on that. And a lot of times they're going to kind of go in and assess the person and be like, yeah, I know what you're saying. Something's not right. Your nurse still may not be sure. That's why it's up to the doctor to figure it out. But you can still move it up the chain and make sure that resident gets the help that they need and prevent emergencies before they happen in the first place. Because that's the best time to prepare for an emergency is before it happens. And the best way to help in an emergency is to prevent it in the first place. So, what do you do if somebody is bleeding? You enter the room, they're on the floor, maybe their arms cut open, and they're bleeding all over the place. What are you going to do? Now, this can be from either an abrasion, which usually abrasions are not going to bleed very much, maybe just a little bit. Those are kind of a scuff or a scratch on the knee. If you kind of remember, if when you're a kid, if you ever wrecked your bike and kind of got that scratchy, scabby stuff, a little bit of blood on your knee when you hit the curb, then that's more like an abrasion. So a laceration is going to be where there's an actual cut on the arm. And this can be caused by either a knife or a sharp object, or it can be caused just by a tearing of the skin. But usually it's going to be a very clean cut line. Now, skin tear, this can be caused by if people have that really, really papery thin skin, they don't have a whole lot of fat, they don't have a whole lot of tissue underneath, that can cause a skin tear. So, you enter your residence room, they're on the floor, they've got a laceration on their arm, they're pumping out blood everywhere, it's going all over the carpet. What are you going to do? First, you're going to stop and get gloves. And at that point, you want to apply direct pressure to that broken skin area using either a sterile bandage or the cleanest cloth available. Now, when you walk into that room and that person is dripping blood all over the carpet and they've got a laceration and they're screaming bloody murder because it hurts, you're not going to have time to stop and say, well, I think I'd like to go get a sterile bandage for this. I'll be right back. No, don't leave that resident. Chances are they're going to have even more bleeding problems, and if they are in a standing position or maybe even a sitting position and they lose too much blood, they may go into shock, and we'll talk about shock in this unit too. So you want to make sure that you apply that direct pressure. So if you don't have that sterile bandage available, go into the bathroom, get paper towels, get a clean washcloth, get tissues, get whatever you can. Put your gloved hand around those paper towels, tissues, whatever it is, and apply direct pressure to that area. Now, you want to be able to slow down the bleeding, but not enough to stop the pulse. If you have an arterial bleed, where one of those arteries is cut and everything's just pumping and gushing everywhere, then you may have to apply enough pressure to stop that pulse and apply kind of a tourniquet with your pressure of your hand. But the goal is not to necessarily stop the pulse. Most of the time, it's just to slow the bleeding out down enough where the blood will naturally clot on its own. So then you want to follow those nurses' directions for additional care. Most of the time, if you've had that laceration happen, you've applied that direct pressure, your nurse comes down and looks at it, they're going to decide, okay, does this need stitches or does it not? If it doesn't need stitches, at that time the nurse will apply an appropriate dressing and get the wound clean. If it does require stitches, then they're going to get them to the hospital and get those stitches taken care of, because nurses can't do stitches, and especially can't do stitches in the nursing home, so they need to get them over to the hospital to get it taken care of. So you may have to do follow-up care, maybe if the dressing was applied by the nurse and they tell you, okay, just tell me if anything else goes on with it. Or if that dressing falls off, I need you to come get me. Or if that dressing falls off, then I need you to put whatever you can on it to slow down the bleeding and have somebody come get me. That may be your follow up for additional care. Just follow whatever they tell you to do. And then also the vitals that we kind of talked about. So, having a nosebleed, bleeding in your nose can happen spontaneously or it can happen after a fall. Now, this is more likely to happen with people that are on blood thinners or people that are on oxygen, even if it is humidified, because it still dries out your nasal passageway and then your nose tends to kind of dry out and bleed. So, if you have someone that has a nosebleed, you want to apply direct pressure by pinching the soft part of their nose just below that bony structure for 5 to 10 minutes. So, kind of take your fingers and reach up on your nose and kind of feel the bones in your nose where they stop, and then pinch just below that. And that's where you're going to have that person pinch for about 5 to 10 minutes. So, you always want to help them sit upright and lean forward as possible to allow the blood to drain out of the nose or mouth. Do not tip their head back, because if you tip their head back, all of that blood that is coming out of their nose is going to drain down the back of their throat and they may choke on it. So always assist your resident to sit slightly forward and pinch the bridge of their nose just below that bony structure. You can apply a cold pack to the nose area if directed by the nurse. Now, we kind of already talked about cold packs and what you're supposed to do with those and how do you avoid injury with cold packs. But what those cold packs are going to do, if you kind of remember, they are going to constrict the blood vessels. So that's what we're trying to do with the nosebleed. We're trying to clamp those blood vessels down where the nose will stop bleeding and stop running blood into the nasal cavity. So you can always apply ice to the nose if the nurse directs it. Always check their vital signs. Sometimes, if someone has a nosebleed, that can be an indication of extreme hypertension, of extremely high blood pressure. So, always check their vital signs because if they have a nosebleed, that could be the indicator to you that we need to get their blood pressure down before they have a stroke or a heart attack. So definitely check those vital signs. And you want to make sure that the person hasn't bled too much and, drop their blood pressure as well. Because sometimes if people have massive nosebleeds and they bleed a whole lot and they lose a lot of blood, then they can get into a hypotension situation and have a low blood pressure. And then you're always going to want to follow the nurse's direction for additional care. So, what do we do about burns? Burns are very tricky subject with these and kind of hard to manage sometimes. So, if you have somebody that's sustained a burn, you always want to remove the resident from that burn source. Maybe they've accidentally stuck their hand on the steam table. Maybe somebody forgot to lock the door back into the kitchen. Maybe the water temperature regulator has messed up and the person has washed their hands and the water got up to 140 degrees and it burned their hand. So, whatever the case is, remove that resident from the burn source. If it is a chemical burn, you want to rinse with cool running water for 15 minutes or more. That's where it comes in handy to know where that MDS sheet is. Or the SDS, I'm sorry, where the SDS sheet is, that safety data sheet. That way, if you find out, oh my goodness, this resident has been exposed to a chemical, they've got a burn on their hand, what do we do about it? For the most part, you're going to want to run cool water over it for 15 minutes or more. And then that SDS sheet will tell you what to do from there. So, for a minor burn, you can apply or immerse the affected area in cool water, not ice, because ice can constrict those blood vessels too much and can cause more damage to the burn area. So, cool water if directed by the nurse. If you see a blister, do not break it because those blisters and the very thin skin and all the fluid inside of it are protecting the exposed tissue underneath. So you want to keep those blisters and not pop them. And then you always want to follow the nurse's directions for additional care. If the burns are severe enough, the person may need to go to the hospital. Now, if you ever have somebody with a third-degree burn, that is very serious, and those are going to be the people sometimes that will tell you that they don't feel anything because their nerve endings are gone. So they've had that severe burn that's gone the full thickness of their skin and damaged the nerve endings underneath. And that's kind of scary to think about. So if you have somebody that faints, now fainting, sometimes it's called syncope, 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 or fainting. This is a temporary reduction of blood supply to the brain that results in brief loss of consciousness. So, to protect our resident from injury caused by the following after loss of consciousness, then we can, if we see that resident starting to fall, we can go over to them and we're not going to try to keep them upright. That's dangerous for you, dangerous for the resident, unless, they're really barely starting to kind of lean over, then you can usually correct them. But if they're already halfway down to the floor, don't try to stop and pick them up. You will hurt themselves. You will hurt yourselves. You will probably hurt them. So you want to assist that resident to the floor. Make sure that they get down to the floor and that you help them into a comfortable position. So that's some of the things that you can help with. So you want to look to see if other residents or other injuries, I'm sorry, have happened if the resident has fallen. Ask the resident when they come to, or maybe look for bruises or something like that. We don't want to move people that have fallen, so you always want to stop and get the nurse. But if the resident comes to right away and they say, "What happened? Did I faint?" Then you can ask them, "Yeah, you fainted. Did you hurt yourself when you fell?" And sometimes they can tell you, sometimes they may not be able to. So again, always assist that resident to a lying position and make sure that they're comfortable and check their vital signs. You may be able to catch whatever caused that fainting spell. You may be able to catch the extremely low blood pressure or the extreme bradycardia or the extremely low pulse. So if you do have a resident that falls, we talk a lot about falls because falls are the number one cause of injury and death in a nursing home. I know I've said that before, so commit that term to your memory that falls are the number one cause of injury or death in a nursing home. So if you have a resident that has fallen, if you see them fall, or if you find them already down on the ground, do not move them. Absolutely do not move that person. You don't know what kind of injuries they may have. If they have fallen and hit their head and hurt their neck, if you move them, they could be paralyzed. I know that that's an extreme situation, but keep that in mind that you could hurt them more even if you are trying to help them because you are not trained to be able to move that person. And that's okay. That's not your job. Don't worry about that stuff. What you do need to worry about is providing comfort to that resident. You may want to provide a blanket for warmth and privacy. If the person is on the ground and has hit their head, most of the time you're not going to want to move their head because you want the nurse to see if they have any kind of neck or head injury. But if they've fallen on the ground and they say, "No, I didn't hit my head, everything's fine, I'm sure my head does not hurt," then you can usually kind of put a pillow underneath. Just follow your facility policy, whatever it is, and ask the nurse maybe, "Hey, so and so's on the ground. They fell on, they say they fell on their bottom. They said they did not hit their head, but she's still on the floor. Can I give her a pillow under her head just to make sure that she's comfortable until you can get there?" That's an appropriate response. But you always want to look around your environment for possible cause of the falling. So look at the lady up in the little picture there. What does that look like to you that caused her to fall? To me, that looks like she may have rolled out of bed. To me, that also looks like she maybe had been trying to get into bed. Maybe she was trying to crawl in with her knees first and slipped off the edge of the bed. So those are the kinds of things you can look at to try to identify a possible cause. Maybe if she rolled off the edge of the bed, we might be able to get her a wingtip mattress. Maybe we can put a mat down on the floor like she has there already. If she didn't have that, then that would be another intervention we can do. Or we can maybe check on her and make sure that she's more towards the middle of the bed. And if she's towards the sides, then we can help her readjust. So always look for the environmental causes for the possible cause of falling because that's where your interventions are going to come from. Again, that's up to your nurse to decide the interventions of what to do after the person has fallen, but we can help them out. Give them a clue of what needs to happen, or what did happen to cause that person to fall and how we can prevent it again in the future. So you always want to stay calm and provide reassurance. Even if you are freaking out inside, try not to show it to your resident. Because if you're scared and they pick up on it, that's going to make them more scared. Because a lot of people, unless they are extremely used to falling, they might be terrified when they fell. They might think, if they've heard of people falling, what's the first thing that comes to mind when you think of an old person falling? Usually, we'll think of an old person falling and breaking their hip. And when the residents may think of someone falling and breaking a hip, they might think of their friends that fell and broke a hip and then they died pretty quickly after that. So they may have that fear on their mind. Or they might think of, oh my goodness, what's going to happen to me if I fall again? Maybe they're in an assisted living and they didn't want to tell you that they fell because they know if they fall very many more times, they may not be able to stay there anymore and they will have to go to the nursing home. And everyone's trying to run from the nursing home if you haven't figured that out by now. Everyone tries to run from assisted living that's in independent living, and when they get to assisted living, they all try to run from the nursing home. So we try to make it as good of an environment as possible, but they're all going to still keep running from it. And falls are a big thing that they're concerned about because they know if they fall so many times, then they're going to have more help and they're going to have to go to the nursing home eventually. So if you have somebody that's down on the ground, again, do not move them, provide a blanket, check the environment, keep calm and provide reassurance, wait with them until the nurse gets there, and check their vital signs. Then you want to follow the nurse's direction for additional care. You may have to start doing those fall vital signs. The vitals every 15 minutes for an hour, every 30 minutes times 2, every hour times 4, and then every shift after that. Whatever the case is, follow the nurse's directions and your facility policy for that additional care. So, what about a seizure? Remember what a seizure is? The convulsions where people just start shaking and they can't control it and they kind of go unconscious sometimes. If you see somebody having a seizure, our absolute number one thing that we have to do is protect them from injury. That is the goal. We are not going to be able to stop the seizure. We're not really going to be able to help them very much because they're not aware of what's going on and they can't control their muscle movements. So we want to protect them from injury. So if you have somebody that's having seizure activity, you need to make sure that they get down on the ground. If they're in their bed, they can stay in their bed. That's fine. That's a pretty cushy environment. But make sure that they are protected, maybe from the wall, or if they have a bed rail for mobility, protect them from that, and make sure that they are not going to hit something. But if you have somebody maybe that's sitting up in their wheelchair, they start having a seizure, get them out and get them down on the ground. Get help, get them out, get them down on the ground. So you want to remove or cushion objects near the resident that could cause injury during that seizure activity. So what you're going to want to do in that case is if you have that resident down on the ground, get a pillow, get a cushion, get a blanket and roll it up. Do something. Get it underneath their head. Because think about it. Their whole body is shaking. They cannot control it. It's not just going to be from the neck down, it's going to be their head too. And people can injure their heads by hitting it on the floor. That's a really, really scary thought. So, our number one goal is going to be protect that resident from injury and get something under their head. Do not restrain that resident during the seizure. You may end up hurting yourself and you may end up hurting them. A lot of seizure activity is very, very strong, and the muscles are very rigid, and there's really nothing you can do with that. So, you need to just kind of stay there during that seizure activity and ride it out. You want to provide privacy for that resident and reassurance to the bystanders. If this is happening in the middle of the dining room, there's really nothing you can do about providing any kind of privacy besides trying to block the resident with your body. But you want to provide reassurance to bystanders. Let them know that you're doing everything that you can to help them, to help the resident. So just kind of be there because it might freak out some of your other residents, it might freak out their families. They may not understand what's going on, and you can just reassure them they're having a seizure, we're going to protect them, and we're going to take care of them. That's all you need to do. So you want to observe the length of the seizure activity. When that seizure starts, or when you notice that it's happening, because you may not be there when it starts, start timing it. This is one of the very, very important reasons, in addition to everything else, of course, but this is another important reason of why you need to wear a watch during your shift. Because If you go into a resident's room, maybe they're not acting right. You're just kind of like, what's going on with the person? Maybe you're talking to them, they stop talking. Some residents will kind of start moving their eyes. Some of them might start turning their head or jerking before they go into the full on seizure mode and start jerking uncontrollably. So, when all that stuff starts happening, look at your watch and start timing. Observe the length of that seizure activity. Then you want to make sure that you keep track of that. You got to observe the length, but then you got to report it on to your nurse. So, after the seizure is over, you're going to have to provide some aftercare for them. So, you want to turn the resident to his or her side to allow secretions to drain from the mouth. Because if you leave them on their back and they have a lot of secretions, then they may get those secretions down into their throat and into the back of their throat, or maybe even down into their lungs. They might aspirate on it, they may gag on it, they might start choking on it and cough really, really bad. So we want to turn them to their side so the secretions can kind of drain out into their cheek and out of their mouth. So the resident may have also been incontinent during the seizure. So you need to provide that personal care as needed. Because think about it, all of their muscles are losing completely control. That doesn't just include the ones that we can see on the outside, that's going to include all the stuff on the inside as well. So, following a seizure, the resident may be slightly confused. This is called a post-ictal state. This can last anywhere from a few minutes up to an hour, depending on the resident, depending on how bad their seizure was, depending on how long it lasted. So, just provide reassurance for that person. Be there for them. Make sure that they're, starting to come around a little bit. Keep checking on them a lot more often. We want to make sure that that resident does kind of return back to normal. So, some of the things that you do not want to do during a seizure: do not ever stick anything in their mouth. It used to be taught that you could put a tongue depressor in someone's mouth, or that you could put a wallet in someone's mouth, or that you could put a spoon in their mouth, because people are worried that the resident may swallow their tongue. It is physically impossible to swallow your own tongue. So, if you put that tongue depressor in the mouth, they may bite down on it, they may break the tongue depressor, they may choke on the tongue depressor if part of it gets caught in the back of their mouth. If you put anything between their teeth, like a wallet or a spoon, they may break their teeth. So, we want to make sure that we don't break their teeth. And I know people are still, again, concerned about people swallowing their own tongue. Well, when they're having that seizure activity, the tongue may drop back and kind of cover that airway. But when they're finished and we turn them on their side, the tongue should move back to the normal position, and they can start breathing again. Now, you want to make sure that when that seizure activity is done, that the person is breathing and that they have a pulse. So, if it's a severe enough seizure, they may stop breathing for a minute and you may have to initiate CPR. Hopefully, that will never be the case, but just in case it is, be prepared. So, what do we do if somebody is in shock? Now, shock occurs when the resident's blood pressure is suddenly too low. Sometimes people can faint from being in shock. So it kind of goes hand in hand with that. So some different things you might observe is that the skin is going to be cool and clammy and may appear pale or gray because they don't have enough circulation going to their skin. Their blood pressure is really low, so all of those vital organs inside their brain, their heart, their kidney, their liver, those are all saying, feed me, feed me, feed me. And your skin's kind of left out in the cold. So that's why they're not going to have good circulation and they might be pale or gray or kind of cool and clammy. They may have a weak, rapid pulse. Again, they have a low blood pressure. There's not enough blood circulating. Their heart's trying to make up for it. So the heart is just going to go and try to go as fast as it can, even if it is kind of weak and there's not a whole lot to pump through the heart. You may also have respirations that are rapid. The heart's working overtime to try to pump out that blood, and it's saying, I need more oxygen, I need more oxygen. So the lungs are trying to work faster, trying to get more oxygen into the bloodstream. You're going to have a blood pressure that is below normal or hypotension. So when you take vitals, you may see a blood pressure of 90 over 60, 80 over 40, 70 over 30. Whatever the case is, you will see a low blood pressure. People may be restless, they may be confused. That may be some of the earlier signs of shock that you might see. And eventually, as the shock worsens, they're going to lose consciousness because their brain is not going to be able to get enough fuel and oxygen to feed itself and to keep going. So they're going to lose consciousness if you don't get the shock treated. So there is a little presentation after this about how to treat shock, but usually get people on the ground, get their legs elevated, put a blanket over them to keep them warm. Absolutely turn or check their vital signs. You may want to turn the victim's head to one side if a neck injury is not suspected. Follow any nurse's directions for additional care if there's anything that you haven't done already that they want you to do. And sometimes you want to put their feet up. If the resident does stop breathing or the heart stops beating, you want to follow that facility policy and only start CPR if the resident does not have a DNR order. So, again, very important to know why or who has a DNR order in your facility. So then what do we do with a stroke? We already have kind of talked about stroke back in chapter 15, but this is a very, very important thing to talk about and know what to do. So we got to think fast. Got to look at their facial weakness. Have to look and see if they have any arm weakness. Have to look to see if they have any speech difficulty. Are they able to talk? Are they having garbled speech? Does it sound like they're drunk? Sometimes it does when they're having a stroke. Then we have to think about the time. When were they last normal? When did the stroke symptoms start? Because remember, time is brain. And the more time that you have stroke symptoms, the less brain function you're going to have at the end. So this is an absolute medical emergency. So if you see any of these symptoms, then you want to make sure to get that resident into a lying position. You want to position them on their side if necessary to help the secretions drain from their mouth, just like we did after the seizure. Do not give them anything to drink. Absolutely not. If they try to tell you, I'm thirsty, well, I'm sorry. I cannot give you anything to drink. Because, think about it. If their muscles are all messed up, they're drooping on their face is weak, chances are all of the muscles in the neck and the epiglottis are going to be weak. So then if you try to give them a drink, what's going to happen? They're going to aspirate. They're going to choke, they're going to gag, and it's going to get down in their lungs. Bad, bad deal. So do not give them anything to drink. So you always want to check these people's vital signs. A lot of time if somebody is having a stroke, they're going to have an extremely high blood pressure, very much hypertension, HTN. So you'll see a really, really high blood pressure. Sometimes you'll see a high pulse. You may not see anything else different. They may have a normal oxygen level. They may have a normal respirations. They may have a normal temperature. But a lot of times your blood pressure is what's going to be elevated. And these people, if you start seeing all these signs of stroke, they need to get to the hospital immediately. So what do you do if your resident ingests poison? We already kind of talked about what happens if they get chemicals on their hands or on their skin. What happens if they swallow it or if they get in their eyes? So you want to save that container of suspected harmful substance for identification. If you have that container, say it's one of the cleaning products that you use at your facility, maybe it's the one that you use to clean the tub after somebody's had a bath. Well, somebody forgot to put it up and your resident got into the bathhouse, or you took them in there to use the bathroom. They're usually safe to stay in there by themselves because everything's locked up. Today it isn't. You notice they're acting kind of weird, and you go into the bathhouse and you see this bottle of chemicals out, the top's gone, and it looks like a lot of the chemical is no longer in the bottle. What happened to it? If there's no spill on the floor, your resident may have ingested it. They may have thought, ooh, That's a pretty pink bubblegummy drink. Let me take a drink of that. And they may not realize until it's too late that it's poison, it's chemicals. So, if your resident vomits, you want to save a sample of that vomited material so that it can be evaluated. Your nurse is going to have to be notified immediately, check the person's vital signs, check on them, tell the nurse how they're acting, whether they're acting really funny, if they're nauseated, if they're really tired, if they're complaining of their throat burning, if they're complaining of their stomach hurting, whatever the case is. That way, the nurse can, have somebody get the SDS. You can look at it, see what are we going to do next. They may have to call the poison control center. They may have to send the person to the hospital to get treated. So it's very, very important to get those chemicals locked up as much as possible. Now, you may have those well meaning families that decide, well, mom just needs some kind of air freshener in her room. It just doesn't smell very pleasant sometimes. So they bring in maybe one of those gel air fresheners, the little cone things. And your resident's confused and they decide, ooh, that looks like a tasty treat. And they eat it. Again, you may not have an SDS sheet on that because that's not a chemical that's supplied by the nursing home. You may not have even known that cone was in there. But that's a call to poison control center to try to figure it out. So this is where education comes in very, very handy to make sure that your family is educated on what kind of things like air freshener and stuff like that can be brought into the nursing home and what can't. Different facilities are going to have different policies, so just know what yours is and how you can help out if somebody decides or doesn't know that the policy exists and what they can and cannot bring and bring something they shouldn't bring. So then we talk about choking. We already kind of talked about choking back maybe in our nutrition chapter, but we're going to talk about it again because it's very, very important to know what to do. So observe your symptoms of partial or complete airway obstruction and just know that choking is what happens when something gets caught in your airway and you are no longer able to breathe, you are no longer able to speak, and you cannot make any noise. So, if somebody is choking, sometimes they will use that universal sign for choking where they'll put their hands over their neck. Now, if somebody's in a panic state, they're choking, they can't breathe, they need help, they may not stop and think, well, I'm not feeling so good. I think something's stuck in my throat. I need to put my hands over my neck so they know I'm choking. Probably not going to happen. So you need to observe for your residents looking blue, looking red, looking purple, if they're flailing their arms a lot of times, if they're pounding their chest, if they, if you ask them, can you breathe? And they shake their head no. Ask them, can you talk? And they shake their head no. What are you going to do? That's when you need to use that abdominal thrust, which used to be called the Heimlich maneuver, to correct that obstruction. So you want to wrap your arms around their waist, make a fist out of one of your hands, wrap your other hand around it, and push in and up. Push in and up on that diaphragm and force the air from their lungs back up their airway, and hopefully it will expel that object out. So when you stop doing the Heimlich maneuver or the abdominal thrust is when either the object pops free or the person passes out. Because eventually, if your brain does not have enough oxygen, you're going to faint and you're going to pass out and become unconscious. So if that happens, then you want to get the person on the floor and start doing chest thrusts or CPR. Sometimes CPR will pop that object out and you can keep going and make sure that that person is able to breathe and they have a heartbeat. You always want to provide reassurance to the person that's choking. Let them know that you're there to help them. Let them know that you are going to make sure that they get that object out and that they're safe again. So this concludes our PowerPoint presentation on first aid in the adult care home. There are a few videos afterwards for you to watch just to make sure that you are comfortable with all the situations. And there may be many, many more first aid situations in the nursing home that we haven't covered. So just whatever your facility is able to teach you and whatever you're comfortable with, just go whatever their policy is. So Please contact your instructor if you have any questions, and have a wonderful day.